Well, hello everyone. So glad you could join us today. My name is Bill Keck, Chair of the Academic Health Department Learning Community and the Council on Linkages, and it's my pleasure to welcome you to today's Academic Health Department Learning Community webinar, which, as you can see, is entitled Utilizing Academic Partnerships to Enhance Capacity in Small Health Departments. Before we begin, however, if we can go to the next slide, I'd like to ask Kathleen Amos to go over some of the housekeeping items associated with the GoToWebinar software we're using today. So if you would, Kathleen.
Absolutely. Thank you, Bill. And thank you all for joining us for today's webinar. As Bill mentioned, as we're getting started here, we'd like to go over a few housekeeping items for the webinar. On the slide, you should see an image of the attendee control panel, which you should also see on the right-hand side of your computer screen. This control panel is your hub for interacting with the webinar. So first, at the top in the control panel, you should see an audio section. You have two options for accessing audio for this webinar, either through your computer speakers or over the phone. If you are using your computer speakers and a mic, please choose the computer audio option. If you're using your phone, please choose the phone call option and enter your audio PIN, which can be found in that audio panel. Please just make sure that you've selected the audio option that you're using. And if you choose to listen over the phone, please also be sure to mute your computer speakers to reduce any echoing. Regardless of whichever option you choose, all attendees on today's webinar are currently muted. The slides for today's presentation are available for download in the handout section of your control panel if you'd like to have a copy to scribble on or follow along. Links included in the slides are not live during the webinar itself, but they are in the handout. So if you download that copy of the slides, those links will take you to any additional resources that are included in the presentation. Throughout the webinar, please submit your questions or comments via the questions box in your control panel. Please feel free to send in your questions for Mike at any time, our presenter today, and we will address as many as possible during the Q&A discussion session at the end of the webinar. When we get to that section of the webinar, please also feel free to raise your hand and we can unmute your line if you would like to ask a question verbally. If you have any difficulty with any of the technology we're using for the webinar today, please also use the questions box to send us a message. I'm joined here in the office by Russ Rubin, our Director of Strategic Communications, and him and I can help troubleshoot any issues you might be having. And finally, this webinar is being recorded, and the archive will be available following the webinar to you and to others who are unable to join us today. Thank you very much.
Indeed. Thank you, Kathleen. Well, some of you on the call are new to us, so I'd like to take just a few moments to fill you in a bit about our learning community background. We are a product of the Council on Linkages between academia and public health practice, and we're staffed extremely well by folks from the Public Health Foundation. Today, that's Kathleen and Russ. The Council is made up, as you can see, of 23 national public health organizations, including the Centers for Disease Control and Prevention and HRSA. Our funding, for which we're very thankful, comes principally from the CDC. And we have three major goals that are listed on the slide for you. And as you can tell, all of them are related to our efforts to link academia and practice increasingly well. The next slide, please. We're often asked just what an academic health department actually is. Well, a wide range of agencies, institutions, and arrangements are involved in these partnerships, making a tight definition really quite difficult and perhaps unnecessary. This slide contains some of the phrases we use to describe these arrangements, and we present them here in hopes they may be helpful to understanding and useful to you. I won't go through each of them, but encourage you to download the slides if you wish to have more time with them. And the next slide, please. The Council on Linkages is perhaps best known for its work to develop core competencies for public health workers. But the Academic Health Department Learning Community is also an important program for us. The Learning Community is now entering its 9th year, amazingly, and our activities are noted in the bullet points on this slide. But if you're not a member, and wish to join us, just drop an email to Kathleen Amos at kamos@phf.org. Kathleen will then make you a member. It's really a tough membership process. You just request it, and you will be one of us. The next slide, please. The learning community has grown now to more than 1,000 individuals since we began in 2011, and over 60 academic health department partnerships have connected with us. Association with us gives you access to the activities and tools that are listed on the slide. And the next slide, please. This picture shows you the distribution of our members across the U.S., as well as the location of the academic health department partnerships we're aware of. There are obviously many more than shown here, but the ones that are indicated are those agencies that have been active with us and have really interacted with us in one of a number of different ways. And that's enough of an introduction, I think. So let me get right down to today's webinar and introduce our speaker. Our speaker today is Michael Anguilano, who is the Accreditation Coordinator for the Kent City Health Department in Kent, Ohio. So Michael, we're looking forward to hearing from you, and please take it away.
Thank you very much, Bill. Hi, everybody. As Bill said, my name is Mike Anguilano. I'm the Accreditation Coordinator for the Kent City Health Department in Kent, Ohio. And I'm really happy to be here today to tell our story as a smaller health department that's been utilizing academic health department models to enhance our capacity as we head towards accreditation. So first off, a little bit about me. I did graduate from Kent State University's College of Public Health with a concentration in health administration and a minor in economics. I began working with the health department as an unpaid intern in May of 2017. I assumed the role of accreditation coordinator on an intern basis in July and was hired full-time this past March. So I'm fairly new at all of this, but even in the short amount of time, I felt that the impact that an academic health department has made for accreditation has been outstanding. As the coordinator, I also do other things for the health department. Aside from directing the accreditation tasks, I also direct and manage the academic health department and all of the accompanying interns and projects. I oversee the performance management and continuous QI activities and projects, and I have been assisting lately with the completion of grant deliverables. So it's not just all accreditation and academic health departments, but a significant portion of my job has stretched into outer areas of the health department. To give a little bit of background about Kent City Health Department and Kent as a city in general, we are located about 20 minutes outside of Akron and about 50 to 60 minutes outside of Cleveland. Kent City has a population that is around 30,000, and that is without the university that is sitting right behind us. The university adds about 27,000 students as of the most recent fall semester, so the population nearly doubles for a significant portion of the year. Our staff consists of 7 full-time staff members and 1 sanitarian who splits time between the health department and another city department. So a very small staff. Certainly makes things difficult when our population jumps so drastically during different portions of the year. The health department is mainly an environmental one. The main programs that it houses are the housing inspections and food and safety inspections. We offer ServSafe classes for our food operators and mosquito surveillance in the summer that is also through Kent State and utilizes interns from the university. So it's a smaller health department, certainly many gaps and barriers to being successful. And the gaps will be looked at later on in this presentation. So the relation to accreditation for academic health departments is very, very strong, at least in our health department. As we all know, accreditation takes a great amount of time, whether it is state, local, whether you're a city health department or a local county health department. A significant amount of time and resources are required to be spent on accreditation. The state of Ohio has mandated that all health departments be accredited by July 2020. Otherwise, there is a risk of reduced funding for those health departments who fail to achieve that status. So pressure has certainly been put on by the state for a lot of these smaller health departments to achieve accreditation status, and the balance is not always balanced. Local health departments like us that are under 10 people, even under 20 people, are held to the same standard as larger county health departments, and makes things very difficult when you have a lack of resources, a lack of time, a lack of staff, and so the academic health department is here and vital to us to fill those gaps so that we can achieve accreditation. It is a daunting task, as many people know. Accreditation is a very thorough, comprehensive look at what a health department does. But like I said, through the academic health department model, our scope of ability has greatly increased and several gaps have been filled. And I can't wait to get into explaining to you how that has all come about. So the partnership began its consideration in 2013, long before I started working there, but the model was in place quite a long time ago. Through the Kent State College of Public Health, we work with graduate and undergraduate students on several different initiatives that have ranged from vaccination research and communication to evaluating internal programs to writing full-blown plans. This past semester, we held focus groups, conducted research on access to care, and have had 4 interns work with us on completing a lot of our tobacco grant deliverables. So it's ranged from a wide spectrum of different areas of the health department that many of these would not have been achieved without the assistance of the interns through the academic health department. So, and we had 12 interns in fall of 2017, and a lot of work was done equally between fall of 2017 and fall of 2018. One of the biggest challenges for us in starting the academic health department model itself was to determine how a student would perceive their role in this giant program. So this is the student's perspective. Undergraduate students have the ability to utilize this internship for class credit, and that requires some work from the academic advisor that they are paired with. Graduate students can lead the internship process and the accompanying interns that they're grouped with for 2 semesters as part of their practicum. So there is real-world experience there given to grad students, and we've had 3 graduate students so far pass through this internship with the 300 hours. The undergraduate students in fall of 2017 opted to conduct this for credit. In this past fall semester, we actually had all of our undergraduate students decided to do this as means of getting a real-world public health experience and opted to not utilize it for credit. So there is certainly some value and some merit in completing this internship outside of school and not having to be compensated for it. Students, like I said, are not required to do the internship for credit, but if they do, we certainly hold them to some different standards. Weekly time logs have been utilized to assure that they reach the required number of hours, and for Ohio, it's 150 hours per semester. We have required weekly group meetings and check-ins with the students to assure that they're on topic and on task. But regardless, whether it is for credit or not, all students at the end are asked to conduct a presentation to our Board of Health, to our governing entity, explaining the activities that they had conducted in the past semester, its relation to the health department, and any other traits, characteristics, things that were learned throughout that 16 weeks. So there is a component to public speaking and presentation that that personally I feel is very valuable and very necessary for outgoing public health students. So far, and this is worth mentioning, so far there have been no financial incentives for students in terms of payment. So despite it being an internship, we have so far managed to not have it as a paid internship, and that has not deterred any students from signing up for this internship. They see the value in working with a health department, a government building, and government workers, and as of now, that has been enough to secure many people who are interested in doing this internship. So the gaps, which is the whole purpose of this presentation, and filling the gaps and how we've managed to do that. The gaps that have been filled directly relate to our health department's strengths, weaknesses, opportunities, analysis. The gaps in accreditation readiness have certainly been filled first and foremost. The lack of quality improvement initiatives, we have been able to manufacture some quality improvement plans, projects, and initiatives out of the academic health department, and been able to leverage those to get other staff members excited and interested in doing QI projects of their own. The lack of involvement in CHIP initiatives, our ability to work with community health improvement project plans and ideas was limited based on the number of staff available, but with the introduction of interns every fall and spring semester, we've been able to be more greatly involved in our CHIP priorities. The marketing of services is perhaps the biggest one for the health department. There is no dedicated health educator, and our marketing ability is certainly limited. But again, with the interns, we've been able to increase the amount of time dedicated to marketing what the health department does and answering questions from the public. All have been filled with academic health department interns. The small staff that we have has most definitely been mitigated by the use of interns. 7 full-time employees have their hands full with plenty of other objectives, and most of which are sanitarians. They have many other objectives that can't be dedicated to accreditation or marketing or health education. But again, with the interns, there's been a greater ability to achieve a stronger sense of communication with the public. And the understaff and staff burnout is related to the small staff. When you have such a small number of employees, there is a level of layering that gets placed on them in terms of tasks that they have to complete. So the staff burnout has been mitigated by the academic health department. So we have the ability to send interns on different meetings, have them do different tasks that would normally be done by an employee, and the academic health department has certainly filled its role there in filling that gap. And as for staff identified weaknesses, a lack of research being conducted, and I know firsthand that there has been a greater level of research done at the health department in terms of conducting focus groups and community events to bring in research and to bring in information from the public that we can analyze and utilize for accreditation. The few data collection opportunities that we currently have increased with the academic health department. And the performance management and quality improvement opportunities, as mentioned in the SWOT analysis weaknesses, there's been numerous opportunities that we've identified, and staff members, as I said earlier, have a greater sense of trying to find opportunities within the health department that I don't think they would have searched for on their own prior. But now that we've got the ball rolling in conducting QI activities, it's started to spin the wheel a little bit faster to get people interested in doing a QI project of their own. So again, the academic health department relationship began in 2013 between the Kent City Board of Health, the City of Kent itself, and Kent State University. A formal letter was sent to the Kent City Manager back in 2014 describing the purpose and the role of such a partnership. And for us, it was a very important opportunity to convey the need to have an academic health department model in place. And it really highlighted that The health department has its shortcomings, as mentioned earlier, with such the small staff and the gaps in services. It was really important to highlight those and to hammer out why a group of interns, a consistent group of interns, was necessary to keep the quality of output from the health department high. The launching of the health department certainly went through some speed bumps. The threat of Ebola made its way up to Northeast Ohio and put the academic health department on hold. The health department also changed its locations twice now, and is potentially moving for a third time. So there are certainly some barriers there. And then there was staff turnover at the accreditation coordinator position and the health educator position that just did not allow for the health department to have a stable person work with Kent State and work with those interns. So there were certainly some bumps in the road and some reasons for why it took a little bit longer to get on track and moving, but so far, so good. So the goals of the academic health department, what we had to outline from the very beginning. First off, we had to create an engaging and impactful environment for both undergraduate and graduate students. Many people did not know where our health department was even located, let alone knew how to work with government employees. So we had to create an environment and an area where they would not only be able to work, but would feel comfortable working there and would be engaged with the projects that we would give them. So we've been able to do that by dedicating some physical space and have a dedicated person work with them for projects and answer questions. We wanted to enlighten students to the inner workings of a health department and how it works. Many of the classes that a student takes, and as a former Kent State student in public health, I know firsthand that there is not a significant amount of time spent on how a health department operates, the hoops that must be jumped through to pass a policy, to really do anything of impact that I think in classrooms is just kind of explain that it just kind of happens, but that's simply not the case. There are checks and balances, and we certainly wanted to bring those to light. We wanted to allow the semester-long internship to be utilized for class credit if students so chose, and as a practicum experience for graduate level students to attract graduate level quality to the health department as more of a leadership role towards undergraduate interns. We wanted to enhance the health department's capacity and scope of ability, and this was a big one, and certainly the reason why we wanted to do this partnership is to be able to do more. The health department, in my eyes, should be a comprehensive resource that the community and the public can reach out to comfortably and feel that they can acquire quality health information. And through the academic health department, we have been able to slowly move towards that goal. We wanted to improve our ability to communicate with the community, and through various outreach mechanisms and tactics, we've been able to push that idea of the health department as a comprehensive health resource, whether that's come in the form of conducting focus groups, going to city council meetings, making regular social media posts. The ability for the health department to be seen more as a reachable resource as opposed to an inclusive part of the Kent City government. We've certainly achieved that level through the academic health department. And last, we wanted to utilize the programs, plans, and projects to achieve accreditation. And as the accreditation coordinator, this is the lens that I look through for all of these projects. And I made the project plans and set forth some goals on my own time so that I could utilize the interns in such a way that allows me to achieve accreditation, or to help the health department achieve accreditation. However, that does not mean that the health department has been entirely successful with the academic health department model. And our first semester of work was in the fall of 2017. I was working as a part-time intern at the time, so time was not very easy to come by for me personally. But we also had several other problems that we brought to light and had to look at really, really closely to see how we could alter and change. The first year was up and down, as I said, and for every success, there was some sort of inconsistency or problem that took away from that experience. We found that there were too many people that were involved, and particularly between the health department and Kent State University, we felt that there were too many. The hierarchy of individuals just was too confusing for students. We had students reaching out to the health department for questions. We had them reaching out to professors and public health ambassadors for questions. There just wasn't a set staff of individuals who students could reach out to. So that was our first issue. The second was that communication was poor, and that really relates to the too many cooks in the kitchen. Communication is key in every aspect of public health. And it just was not easily attainable with these interns. So that prompted another change. There was not enough structure. There were no work plans devised prior to the implementation of these programs. So there was an inability for students to understand what they would be doing for the 16 weeks. We did not have dedicated plans for those 16 weeks, and it was not mapped out well enough. Many times projects would go week to week. As in we would have new ideas start on a Tuesday and we would have to try to implement those by Friday. We did not have dedication to structure on our side as well. And then the wavering student interest, by the midway point, we had found out that some of the projects that we had designated simply did not have enough meat to them. So we had students that were beginning to do work in other classes and prioritize that as opposed to the internship. So certainly disinterest leads to disengagement and poor work. So those four issues were our biggest takeaways as problems with an academic health department, and probably problems that many health departments have faced in working with students. So in light of that, we had to go back to the drawing board on several occasions, and we had to alter how we went about conducting this set of programs, because we certainly didn't want to give up on it after one semester. We felt it was far too important in achieving accreditation, and it was far too important to the output that the health department was able to achieve. We felt that we were able to do a lot more. So in light of that, we reduced the number of people involved with the interns to one health department staff member and one ambassador or individual from the Kent State College of Public Health. This made things very, very simple. They would reach out to me, the interns would reach out to me, and if I had a question that was higher up, I would divert that over to Kent State University, particularly if a student wanted to do this presentation for credit, then they would reach out to me and I would reach out to their ambassador or their advisor on their behalf. So we greatly reduced the number of people who were involved. The programs and projects that we decided upon were chosen in the summer, about 6 to 8 weeks before school had started. They were accreditation based and very, very succinct and to the point. Detailed work plans were made that had week-to-week goals and intern expectations. It had due dates. It had required work by the end. And it showed that there was a presentation at the end of the internship. So we had week by week showing of what was expected, as well as the time logs if that was necessary. And students felt much more prepared for that semester of work. Interns were interviewed by the health department staff prior to being placed in one of 3 groups. So prior to the school year starting, we sent a memo to the university saying that the health department was looking for interns in 3 specific goals, or I'm sorry, in 3 specific program areas. They would come back to me with a list of students interested, and we would set up one-on-one interviews. Some of the students were unable to do the interview one-on-one and actually sent me several documents from a resume, cover letter, and letter of interest about a specific program. But it allowed me to properly place a student in a topic that they were interested in, as opposed to the previous semester where they were siphoned into different projects without really being asked what they preferred. So this led to a higher output of quality work, students being interested in what they were doing and engaged with the topic at hand. Weekly group meetings with the health department were required. This is the communication part that was very elusive to us in the first semester. And students made time for it. They came prepared and engaged with questions, and we are continuing to do that through the January month already with interns. I actually have interns coming in tomorrow to continue to work on the tobacco grant. So the weekly meetings have worked very, very well. And we wanted to have some form of leader who was not a health department staff for all of these interns. So we decided to have one graduate level student. If they were to come to the health department, they would be the designated leader for any particular project. These projects stretched 2 semesters, but it gave the interns somebody to speak to that was not me, and it allowed them to talk to another student, which is perhaps easier to speak with than an employee of the health department. And then the graduate student would meet with me frequently to update status for the particular program at hand. So it was a little bit of a checks and balances role as well. And so far, like I said, we've had 3 graduate level students come through here and be the designated group leader. And it's a good experience as a graduate student to be given a position of power. So we felt it's been very beneficial to keeping the undergraduate students in line and on task. So currently, or rather at the end of the fall semester, which did just wrap up, we have been able to do the following through the 2 semesters of work, just the 2 semesters through the academic health department model. We've held 4 community events, including a focus group on vaccines in 2017. We've had 2 roundtable discussions with the LGBTQ community about their ability to access care and how they acquire HIV testing within the city. We've held a discussion about tobacco cessation and policy with local stakeholders. And those 4 events are 4 more events than the health department has ever done previously in terms of a focus group. So it's been very, very successful so far with the reaching out to the community. We've mapped out all of the health services in the city, provided a GIS map through the Kent State Geography Department of all of our health services. This was another accreditation task. It took a long time to have students go through each service with me and map them out in Google Earth and have the geography department put out a map, but it's been a very, very rewarding experience as you can do a whole lot with seeing the distance between health services and transportation routes for public transportation. There is a whole lot that can be done with this information. We've created a brochure and other marketing materials for health services in Kent. Again, allows the community to come in and see a physical brochure that the health department made. They take that home with them, and it lists all the contact information from health services in and around the city, from tobacco cessation services to children's care, to women's care, and even elderly care. So this has all been done possible through the academic health department. And the fulfillment of several grant deliverables, and that is still a priority as we head into January and February and the next spring semester. We've been able to fulfill several grant deliverables, often weeks and weeks in advance, through the academic health department and the interns assisting. It's been a wide range of tobacco topics, from policy analysis to forging relationships with local stakeholders who want to support us in our anti-tobacco initiatives. We've created advertisements that have been placed on local transportation, marketing campaigns. We've conducted surveys with local health service stakeholders and their role in tobacco cessation. And we managed to pass Tobacco 21 policy in the city of Kent, a very large step in tobacco cessation and combating the harmful vaping trend that has happened in the state and in the country as a whole. But perhaps most importantly, through all of these projects and all these programs, we've become a more valuable resource to the community and to other community stakeholders who may at one point have not really relied on us for specific tasks and things, but now actually seek us out and want support and want to work with us. So it's been a very rewarding experience, to say the least, in working with the community and working with other entities that are in and around the city. And as for accreditation, just a quick highlight of the areas that the interns have been able to fill in accreditation gaps. We had a full risk communication plan made by 4 interns, a Board of Health approved in October, and that fulfilled an entire measure. And the research done with our immunization clinic and our 90-minute focus group that resulted from that was able to fulfill some of the more challenging measures, including measures from Domain 1, which is a troubling domain for many smaller health departments, as it's a lot of primary data that has to be collected. Program evaluation. We had our large mosquito surveillance program go through a rigorous evaluation with our interns. Assessment of access to care and analyzing barriers. Access to care is a very large portion of Domain 7. In fact, it's almost the entire thing, as well as Domain 3. So our interns have gone in and done a lot of really great work to fill that gap. And then with our tobacco grant, we've been able to fill 2 more measures in Measure 1, the challenging Domain 1, and in Domain 10 as well. So many areas have been filled by interns conducting work or helping us conduct work, and we certainly wouldn't be in the position that we are in without their work. And we did manage to apply for accreditation and submit our documentation this month. So a big reason for that is the interns helping us with all that work. So it's a big step in the right direction, and it's proof that this model works, particularly for smaller health departments. So in conclusion, and based on our evaluation, as in public health, we evaluate everything. So we did a survey to our interns at the end of the first semester back in 2017, and we found that on a scale of 1 to 5, with 5 being an enjoyable, worthwhile experience, I asked a series of questions, and our average response was about 2.6, 2.7-ish out of 5. So it was not nearly as high as we were hoping, but by the end of the second semester this past fall, I just actually collected the final surveys yesterday, and our average rating bumped up to a 4.7 in terms of usefulness and time well spent, because students evaluate their time a lot more differently than we do. And it's hard to really gauge what a student has going on in their lives with their other classes and with life in general. So to say that they found their unpaid internship worthwhile and valuable to their public health growth is really meaningful and really shows that this model, again, is effective and works. And the academic health department has certainly proven to be very valuable to us in terms of completing tasks and reaching a broader audience within the community. And I certainly can't imagine achieving accreditation status without them in the future. So it's been a very worthwhile experience, and we're really excited to keep it going into the spring and into next fall. And that is that.
Terrific, Mike. Thank you so much for your presentation. We now will open the floor for questions. Remember, you can raise your hand, and I believe Kathleen or Russ can unmute you if you wish to speak with us, or you can type your question into the appropriate message box on your screen. So, Kathleen, do we have any questions at this point?
Absolutely. Thank you, Bill. We do. We have quite a number of questions, so I'm going to try to keep track of all of them. And as Bill said, please do continue to send them in, or if you'd like to speak, just raise your hand and we can unmute your line. So Mike, we have quite a few questions about some of the specifics in terms of how you operationalize your partnership. I think you spoke to a little bit of this during your presentation, but at any given time, what is the average number of interns that you might have in the health department?
So our first semester, we had 12 interns. We had three projects, 4 interns for each project. And we quickly found out that without the proper hierarchy of individuals in place, that 12 interns was simply far too much for us. So we moved down to 7 this past fall, and we found that that was a much more manageable number. And the results also show that the health department was able to be more greatly involved with them throughout this whole process, evidenced in the survey reviews that I received. So we went from 12, went down to 7, but I would meet weekly with these interns. So there were times when I would get all 4 for about an hour, hour and a half, where I would meet individually with them at the health department. So it really fluctuated, but we found the sweet spot was around 7, 9 or so.
Great, thank you. Continuing on the theme of interns, I think we have a number of questions about interns. Our next comment, great presentation. Our MPH and undergrad public health program at the University of Missouri is also embedded in a rural area with small health departments. Do you ever utilize online students for any of your internship activities? I.e., are there any students who would work remotely with your team?
I've not had a dedicated online-only MPH student work with us, but it would not be difficult to do some of the work remotely if that was required. A couple of the interns who worked with us last fall have opted to work with us this spring, as well as we continue completing deliverables for the tobacco grant. And I've worked with them over the phone, in calls and over Skype, but that was for shorter periods of time. That was only while they're on their current winter break. So some things have been able to be done over the phone or online and digitally, but as of now, we've not utilized a fully online student who was unable to be with the health department for at least a week, at least once per week. So it's certainly possible, but we just haven't made it quite to there yet. Still trying to work on the physical in-person students first, but it would be certainly possible.
Mike, we got an operational question here. How do you handle having enough workspaces and computers for all your interns?
So the health department has an upstairs area that we've been able to rejuvenate into a dedicated workspace for interns to go up to that have computers. But we have laptops at the health department that can be used, but we're small enough and compact enough that students who bring in their laptop are able to utilize their personal laptop for a lot of this work. We don't hand them certain documents and certain things I will have to handle or someone else at the health department will have to handle. But we've been able to use a dedicated portion of the health department to allow them to go up to and work. I've held meetings at Starbucks. I've held meetings, off-site on campus. I've come to them to do work if it's too difficult for them to come to the health department. So I guess the key for that would just be flexible. And so far we've been very, very flexible, and it's worked out well.
Excellent. Sorry, I'm just scrolling a little bit here. There are a number of academic health department partnerships that incorporate students who are in programs other than public health programs, so like medical, nursing, dentistry, pharmacy. Do you have any thoughts about utilizing non-public health degree programs in your partnerships?
It certainly has been discussed, particularly nursing. And we started to kind of move towards the geography department as early as last fall. We had a lot of things we wanted to map out in GIS, and we really saw the power of GIS and the ease of use when we were mapping out our health service locations. So we did delve into the idea of utilizing some geography interns as well, but so far we have not actually put that into action, but it is something that we will deeply consider moving forward as we start to expand and have different ideas. But nursing and geography would be so far the two areas that we have looked into.
Nice. And as you're thinking about that and thinking about the continuity of your program, have you thought at all about creating a systematic pipeline for students, or how do students discover that this opportunity is available, or the different projects that you have available?
So the only method that we used this past fall is working with the College of Public Health at Kent State, and they have a listserv of well over 1,000 students, undergrads and graduates, and I planned out, and the health department and we planned out the programs and the ideas long beforehand, and we advertised them as such. We advertised what the areas were that we were going to work on. We advertised, the number of interns, the type of people that we were looking for, We sent that to the College of Public Health. They sent it out to that whole cohort. It was put on their social media page as well, I believe on Facebook and on Twitter. So that's the easiest way that we saw to acquire interns. We didn't really want to do the physical flyers or anything like that. We didn't feel it would be really necessary, but because we were doing this in the summer, we didn't really have the ability to go find interns physically. We had to reach out to them digitally. And that's been our only way of doing it so far.
Great. And you mentioned, a lot of your interns are working on large projects that are very large in scope. How do you bridge the gap between projects so that if one student has worked on a project in the past that still needs work to be done to complete the full project, getting new students involved to be able to finish the project, how does that work?
Well, we have not had that problem yet, and that is a testament to the individuals who want to stay and continue the work into the next semester. But ideally, because we have at least one graduate student on each project that's required to do 300 hours, which is 2 semesters worth of work, we will have myself and the graduate student, who are the 2 holdovers from the previous project. So that's how we bridge the gap, is through that leadership role that the graduate student has undertaken, as well as my expertise on the program or project or task at hand. But we have not had to deal with that yet. I'm sure that we will at some point, but as of now, it would look like I'd have to catch people up myself, and I'd have the graduate student intern assistant to help me with that.
Great. Some more kind of logistical or detailed questions. Do you have an idea of what percentage of an FTE, excuse me, I can't speak, an FTE is needed to handle the internship program, the students, and oversee all of those activities? Is it a full-time job? Is it a half-time job?
The internship?
Yeah, the students, yes.
Well, if it is for a class credit, it'd be 150 hours. So that's roughly 10 hours a week if you're looking at a full semester. So I guess it could be seen as a part-time job or even less. But for a graduate student, they have much more say in the activities that are done. But as a undergraduate student who is doing this for 1 semester and they're out the door, so far, they have all seen it as a part-time job. They come to the health department for a couple hours a week and speak with me and work with me. So as of right now, I would categorize as a part-time job for an undergrad, but for a graduate student, it's a lot more demanding, and that's on their academic end, as well. They are required to submit time logs and verification that they're doing their end. So I would say it's different for each level of student.
Okay, great. And on your end, how much of your time do you think on a day-to-day basis or weekly basis is spent managing this program?
In the fall, I would meet with every group once per week. So at least 4 hours would be dedicated to that, plus some other programming work. I would say between 10 and 15, and sometimes it's more, sometimes it's less. If you're leading up to the night of a focus group or some sort of community event, it's obviously a lot more work. And then right now it's kind of in a lull period with students out, so it ebbs and flows. But I would say between 10 and 15 hours, sometimes more, sometimes a little bit less. Okay,
great. One of the things you talked about, Mike, when you talked about the challenges in building this AHD relationship is a lack of structure. So there's a comment about you mentioning lack of structure, and we realize students are very used to prescriptive course syllabi. Do you have any recommendations, or could you speak a little bit more to any thoughts that you have about engaging students and helping to create the work plans to fill their internship time appropriately in ways that will most benefit the health department?
Yeah, that was the most challenging aspect, I think, to deal with when I received my first round of surveys back in fall of 2017 was hearing that their time was not well spent. And that was certainly hard for me to deal with because on my end, it seemed like a whole lot of work was being done and there was so much being done. But it was difficult to put myself in the students' perspective as to how would they be spending their time. So for the work plan, I really went week by week and what I wanted to see done in all of those weeks. And if I wanted something changed or if a new task had come up, I went back to the work plan. I rewrote it, reformatted it, and edited it, and I sent it back out to that student. It really took a significant amount of time to plan it out, because even in my head, when I was working through this, I was even thinking to myself, well, I need to make 150 hours worth of material for interns. How do I do that? And it really took quite a bit of time at looking through the grant. So the tobacco grant was the easiest because we had set deadlines there already, but for some of the marketing for the access to care and some of the focus groups, we had to get creative in how we utilized our students. So that would involve off-site work to do our focus groups, or that would involve me asking them to do some research, on a policy. Look at a policy that has been done already, or give me 5 example policies for tobacco 21, and tell me what you think about them. So I had to get creative with how we utilize their time. But as I went through each program idea and looked at the accreditation requirements, a lot of the tasks were taken straight out of the PHAB guidance. So I was able to put those directly to work, and I made sure that they were fulfilled when the project was done. But it took some time, but as we started getting into the accreditation and really going through it, it became a lot easier to map everything out.
Great, and I'm sure as part of that process too, you also have to think about the projects, how the projects match the course objectives on the academic side.
Correct.
Yes. With a couple questions related to assessment, do you use any type of pre and post assessment form to measure student intern achievement of public health skills? So kind of measuring what they're learning.
There is no specific test because as of now, the things that I've been teaching, so to speak, I'm not a professor. The things I've been attempting to teach have not so much been things that you get out of a book. It's been the ability to come with me to a meeting about, it's a community substance abuse meeting. Come with me to the meeting and be engaged and discuss that with me, at a later date. Or come with me to a CHIP meeting and see all these stakeholders within the community and speak with them and gain some real world perspective. So there's not a set series of things I want people to learn because it just changes for every single program. But I do have a post-test survey, and last fall when we had every student there who was doing it for credit, we did have a evaluation, and then we had a midterm evaluation as well, and then we had a final evaluation, and the students would evaluate us and I would evaluate them so that I can hand it to the preceptor so that they would have a good idea of how the student performed. But there is no set standard for me, at least, on what a student needs to get out of this. I think they get out of it what I put into it, and to me that's taking them to meetings and having them meet people and be engaged in community activities that I don't think they would normally otherwise be subjected to.
Absolutely. Mike, are there any formal documents or agreements that are signed around the partnership, or is it more of a working relationship?
It is a working relationship, I would say, but I believe we do have a written agreement in place that was signed before I was hired. So I'm not well versed in that language, but it was heavily discussed with Kent State, and we have many members of the Kent State public health staff who sit on our board. So the working relationship was not easy to make work even better for this partnership. But there is an agreement in place, but it is more of a working one, yes.
Great. I know we're getting close to time here. We do have quite a number of questions left in the chat box. Please do feel feel free to continue to send those in, and we can follow up after the webinar for the questions that we're not going to get a chance to answer live during the webinar itself. I do want to take a couple minutes before we close. There are a number of questions related to resources, so I wanted to just run through those.
Sure.
Someone asked about whether an archive of this presentation would be available so they could share it with their accreditation team. Yes, we are recording it right now, and we will have the archive available, and that will be sent out to everyone who registered for the webinar today, and it will be available on our website. So you can feel free to share it with others. We'll make sure you get that link afterwards. There's a question about the map that we had of the academic health departments earlier on in the slides. We're also happy to share that as well. The list of AHD partnerships that is based on is on our website. I don't know, maybe Russ, we can dump that in the chat box right now.
Sure.
So if anyone wants to look at that right now, you can. But we're happy to make any of our resources available to you. Mike, there's a couple questions about the internship program and resources that you have to run that program. Let me just scroll back really quickly. Let's see here. So any kind of evaluations, any of the work plans, those sorts of documents, if you would be willing to share those with the group.
Sure, yeah, absolutely.
And also a question, I think, in your, perhaps your current work slide, I think there was a mention of a health services brochure that you're going to have available on your website. If we could share the link out of that with the audience as well today, I think that would be appreciated.
Yep.
So we can follow up with you to get those resources and pass them along to everybody. Also, someone typed in the chat box that they'd love to have you come to one of their conferences. They're really enjoying your presentation. So we can follow up on all of that kind of stuff after the webinar. And I do thank you so much, Mike, for this. This has been great. I do want to give the floor back to Bill for just a couple of minutes to take us through to the end of the webinar.
Thank you very much.
Indeed. Thank you both, Mike and Kathleen. Well, we hope you've found this afternoon's webinar informative, and I'd like to join you actually in thanking our presenter, Mike, for sharing his expertise, time, and experience with us. The last slide is here to give you an overview of the resources available through the Academic Health Department Learning Community to those who are interested in exploring the nature of academic and practice partnerships, of how to develop new relationships, or how to maintain and improve existing relationships. And in addition to our regular webinars, you may wish to interact with our so-called Ask the AHD Expert column on the Public Health Foundation Pulse blog. You could also examine our library of AHD resources and tools on the Public Health Foundation website. And if you don't already receive it, sign up with Kathleen for our newsletter called the Council on Linkages Update. And that, I think, brings us to the end of the webinar. The top of the hour is at hand. So let me thank again our presenter, Mike Anguilano, and all of you for joining us for a very spirited and I think very informative session this afternoon. So good afternoon to all.